Dr. Rajat Mathur. Yes, he is going to be talking on RayOne EMV Toric lenses.
Good morning, dignitaries and the friends and colleagues sitting in this hall. Today I will be talking about the RayOne EMV Toric IOLs. There is no financial interest. It is a journey from the quantity of vision to the quality and quantity of the vision. First we had this spherical lenses, PMMA lenses, spherical lenses, then aspheric lenses, then multifocals. Now we have extended depth of focus lenses, trifocals and advanced monofocals. These are the modern IOL classification, but I am mainly concerned with the monofocal plus lenses. This is the basic classification which I follow. It is monofocals for distance vision, monofocal plus for distant intermediate vision 60 centimeter onwards, extended depth of focus EDOF distant intermediate 40 centimeter onwards, multifocals for distant and near, trifocals for distant intermediate and near. According to pupillary dependence, there are monofocals and monofocal plus lenses which are pupillary independent, and EDOF and multifocals and trifocals which are pupillary dependent. What is a monofocal plus lens? This is nothing but there is an elongation of the focal length of the monofocal lenses. It gives slightly intermediate vision beyond 60 centimeters. And how do these monofocal lenses are modified? This is done mainly by two methods. First is a supple increase in the anterior curvature of the lens, which is done by Johnson & Johnson eye hands, and the other is by increasing the positive spherical aberration of the lens, which is done by RayOne EMV. Both these methods slightly elongates the focal length, thereby giving some intermediate vision, and as there are no central rings or humps, therefore it makes the pupillary independent. This is the design of the spherical aberration based optic design, and this is the high order aspheric optic design. Spherical aberrations occurs when all incoming light rays ends up focusing on a different point. These IOL based on the spherical aberrations can offer some depth of focus, but affects resolution and clarity, making it hard to obtain a sharp image. This is corrected in this RayOne EMV by blending of the longitudinal aberrations. And this is the only lens which can achieve a micro monovision type of thing. The other one is the refractive technology based on continuous higher order aspheric surface, and there are no rings, no zones, and not based on a spherical aberrations. How does the RayOne EMV works? It is an anterior spheric surface with unique center region induces controlled postural spherical aberrations, which extend the depth of vision. Blended edge reduces longitudinal spherical aberrations to maintain visual acuity and contrast sensitivity under low light condition. And non-diffractive design offers reduced dysphotopsia compared to the diffractive optic designs. RayOne EMV does not use diffractive light splitting optics. We can see the blue one is the zero spherical aberrations and the pink one is the RayOne EMV. So the patient should not experience dysphotopsia than with the standard monofocal IOLs. The patented RayOne EMV positive spherical aberration design works together with the natural positive spherical aberration of the cornea. Therefore, it maintains higher performance under normal levels of tilt and decentration when compared to negative spherical lenses. What is the effect of the positive spherical aberration? First, the patented RayOne EMV optic maintains monofocal quality of distance vision. You can see the blue one is the monofocal lenses and the pink one is the RayOne EMV. While uniquely redirecting both myopically, to extend depth of focus for excellent intermediate vision, and hyperopically 0.3 for the wider landing zone. This 0.3 which you can see is the quality which can be used for making it for a micro monovision type of thing. This high quality vision, enhanced monovision, and rotational stable RayOne Toric platform. What is enhanced monovision? When offsetting the second eye for monovision, the depth of field now reaches past the intermediate. You can see with the first slide, it's a micro monovision, 0.5 diopter difference is there. The depth of height is passing the intermediate distance, and the hyperbolic extension of the unique patented allows patient to maintain excellent binocular vision. You can see the shaded portion with what is 3. It maintains the excellent binocular vision when you're doing a micro monovision. This is the E-metropic picture When you do a dominant and non-dominant eye, you get a intermediate beyond 60 centimeters for both eyes, but when it is a binocular vision, you get slightly better than that. With this, when you do a micro monovision type of thing, it's a mini monovision when you are having a minus 0.5D diopter in the other eye. Modest if -1, and full monovision is -1.5. This is the box of the preloaded EMV Toric, and you can rightly see the biometry, the A constant is 118.6 and 118.0. But when you go to ray trace Toric calculator, it is the method is being used. There is no mention of the biometry, so you can easily put the method which you are using. It's a contact or a optical or a immersion, so it will give your readings. And you can fix a target refraction as well. For the first eye, you can fix a emmetropic, a dominant eye, or for the second non-dominant eye or the second eye, whichever you take, you can fix it for -0.5 or -1 or -1.5. And you will get 3 results. One will be slightly hypermetropic type, first one, other will be emmetropic, and the third one will be a myopic one. So in my practice, I usually take the middle one for the first dominant eye and the second one, third one for the other eye. I have been using these lenses for last 12 to 14 years, but since last 12 years, when they have got this patented for the 360 degree M1 apple square, there is no PCO. The PCO rates are much decreased. And it has got one of the finest preloaded injectors. I haven't used anything better than that. Hoa is comparable, but this is one of the best I have ever used. Visual outcomes, 82% gets 6/6, but 100% gets 6/9 and above. For intermediate vision, it is 100% for N8 or N10, and 87% of eyes for N10 for the near visual. 94% patients are satisfied with 6/6 or 6/9, and 50% are completely spectacle free if you do a micromonovision type of thing. Key takeaways is significant cylinder reduction with the torics, distance visual acuity similar to those expected from the monofocal lenses, intermediate range of vision is good, near vision is good when we do both eyes, predictive refractive accuracy and patient satisfaction is very good. This is a small video. You have to go to do the markings while the patient is sitting in the right posture in the slit lamp. After that, in the OT, you have to mark again to reconfirm, and you have to mark that point of incision. I have to do it at 125 degrees. The lens which I has used had a 5-degree cylindrical axis to be done. I marked the 5-degree cylindrical axis. Normal phaco is to be done. Good rexes. And the lens has to place in the bag. And the axis has to be aligned. It's a 5-degree or a 6-degree. Very clear marking of the lens. And this was the result. Next day 6/6 from the right eye, and this was the picture. Thank you.
Thank you very much for detailing on a